Hi, good morning. My name is Ernesto Herrera. I'm a second-year resident of the Radiology Department in Hospital Universitario, and this is my interesting case. Clinical history, we have a female patient, 24 years old, with a background history of mellitus diabetes, comes to the emergency department due to intense abdominal pain of 1 month of evolution, accompanied by fever that does not respond to antibiotics. On physical examination, the patient presented pain on the palpation, mesogastrum, and hypogastrum. A contrast in CT scan was requested with a suspicion of abdominal sepsis. Well, at first, we have an abdominal contrast in CT on long window. I'm going to roll it. At first, we saw bilateral coherent effusion and some atelectasis. Here we have the venous space in a soft tissue window, and I'm going to roll it. At first, we saw a hepatic cyst, some kidney cysts, and the most important is this lesion, as you can see. Okay, well, we can appreciate these large lesions depending on the uterus, which is increased in size with lower edge and heterogeneous density at the expense of this nodular lesion, with peripheral contrast enhancement associated with a lot of error. There is also some free fluid in pelvic cavity. Here we have two sagittal reconstructions of the abdominal CT, where we see a hypodense lesion on uterine fundus associated with air and free fluid. With all the previous findings described, as well as the patient's symptoms, it was concluded as a diagnosis of pyomyoma. Pyomyoma is a rare but life-threatening ending condition resulting from infection of the uterine leiomyoma. Pyomyoma are sepsis, leiomyoma, and no other source of infection. It might present with silent or non-specific symptoms, which results in delayed diagnosis and treatment. This infection can be diagnosed in reproductive age woman and postmenopausal woman. The etiology, epidemiologically, this is a rare disease because it has been declined secondary to other antibiotic therapy. Pyomyoma is often associated with polymicrobial infection. Etiology, it is associated with several clinical conditions like post-dilatation and curettage, postpartum vaginal or cesarean delivery, ascending uterus infection, cervical stenosis, post-uterine artery embolization, postmenopausal patient secondary to ischemia, resulting from hypertension, diabetes, or atherosclerosis. On ultrasound, we can find heterogeneous pelvic mass or discrete leiomyoma with cystic and solid components with diffuse foci or regression artifact due to gas. Here we are seeing a transverse ultrasound of the uterus, where we can see a large hypoechoic mass with this echogenic foci that shows shadowing artifact. On CT, on non-infants context CT, we can find an enlarged uterus with gas, fluid, and hemorrhage with leiomyoma, within a leiomyoma, and in contents infant CT, we can find a leiomyoma with gas and internal debris. Might be heterogeneous attenuation with regions of degeneration associated with parametric inflammation. Here we are seeing a sagittal content infant CT of the pelvis that demonstrates a large necrotic fibroid arising from the uterine fundus containing gas, surrounded by diffuse inflammatory standing, fat stranding, and free fluid. Thank you for your attention.
Good morning, my name is Jessica Karen Torres Garcia. I am a second-year radiology resident at Hospital Universitario Dr. José Letre González, and this is my interesting case called persistent trigeminal artery case report and the review of the literature. Okay, medical background. We present a 55-year-old female from Monterrey, Nuevo León, housewife and Catholic. Her medical history, familial history, and non-medical history was questioned and denied. Her chief complaint was burning pain in the left hemiface. So, a 55-year-old female patient who presented with a 10-year history of left hemiface pain, 8 out of 10 in the visual analog scale. The patient attended multiple physicians treating her condition with carbamazepine and NSAIDs with no improvement. Due to this condition, her physician requested an MRI for her evaluation. Okay, first of all, we observe a simple head MRI in an axial plane. At the bones level, here, at the bones level, we observe that from the basilar artery, another artery is arising, which has an anterior direction, making contact with the trigeminal nerve, and then the artery anastomosis at the fourth segment of the internal carotid artery in this way. So at sagittal plane, the artery is observed in direction to the carotid artery, creating a sign similar to the Greek letter tau. Moreover, in this plane, we can observe that the artery is in contact with the trigeminal nerve when the nerve is direction to the Meckel scale. The final report was the persistent primitive trigeminal artery as anatomical variation in contact with the ipsilateral trigeminal nerve. So I will continue with the review of the literature. Okay, about the introduction, during the embryonic stage, the vascular development of the central nervous system, specifically when the embryos measure between 3 and 4 millimeters, the posterior circulation, represented by the primitive vertebrovascular system, depends mostly on the anterior circulation, represented by the anterior circulation internal carotid artery. In this stage, the primitive vertebrovascular system gets its blood supply from 2 pathways. A lower percentage through the incipient posterior communicating arteries, and higher percentage through a series anastomosis between the internal carotid artery and the basilar artery called persegmental dorsal arteries. Such anastomotic arteries adopt their respective names according to the nearest cranial nerve. Thus, the persegmental dorsal artery near to the fifth cranial nerve is called trigeminal artery. The closest to the eighth cranial nerve is called acoustic artery. Okay, and the closest to the 12th cranial nerve is called hypoglossal artery. These connections are obliterated and disappear when the embryo reaches a maximum size of 12 to 14 millimeters, being the trigeminal artery the last one that obliterates. There are cases in which it remains after birth, being called trigeminal persistent artery. The prevalence of this disease it's between 0.1 and 0.6%, with a slight predominance of females. Okay, the objective of this case is to analyze the importance of reporting the persistent trigeminal artery as an incidental finding in Imagen studies. Classify it according to the anatomy. We will see the Saltzman classification and demonstrate the impact that generates in the patient's symptomatology, therapeutics, and probable complications that could occur. Salas classified the trigeminal artery based on its relation to the sixth cranial nerve, distinguished a medial or sphenoidal, and petrous or lateral variant. This classification has a clinical importance due to the lateral variance has been associated with a higher frequency of ischemic cerebrovascular disease, depend of the posterior circulation, trigeminal neuralgia, and sixth cranial nerve palsy. Meanwhile, the medial variant has been associated with the posterior fossa symptoms secondary to artery steal syndrome. And the Saltzman classifications, Saltzman in 1959 proposed a classification in relation to the union of the trigeminal artery with the vertebrovascular system, distinguished two main types, Saltzman 1 and 2. Here we can see as number 1, okay, the number 1 is the persistent trigeminal artery, and 2 and 3 the basilar artery, divided as proximal and distal. In type 1, the trigeminal artery joins to the basilar artery between the superior cerebellar artery and the anterior inferior cerebellar artery, and the region of the basilar artery proximal to the junction is usually hypoplastic. In addition, two posterior communicating arteries are also hypoplastic or absent, and the trigeminal artery is responsible for administering almost all of the flow to the distal basilar artery to both posterior cerebellar arteries. In the type 2, the trigeminal artery joins to the basilar artery in the same region as type 1, but the posterior communicating arteries remain permeable and provide the necessary blood flow to the both posterior cerebral arteries. In this type, in the type 2, the trigeminal artery is only partially responsible for the flow to both superior cerebellar arteries. Okay, the clinical manifestations are divided in vascular abnormalities and the clinical condition. The vascular abnormalities are high frequency of aneurysm, AVMs, moya-moya disease, the carotid cavernous fistula, and the trigeminal cavernous fistula. And the clinical conditions are ischemic stroke that depends from the posterior circulation, vertebrovascular insufficiency, and subarachnoid hemorrhage, ocular nerve palsy, and trigeminal neuralgia. The diagnosis is made by imaging. We usually see this type of anatomical variant as an incidental finding, and the studies that can help us to visualize in the better way are an angiography, angioresonance, this one with the help of reconstructions in MIP. In the upper image, we can see the sign of the Greek letter tau, that it's formed by internal carotid artery, okay, and the union of the persistent trigeminal artery, which is better visualized in the sagittal cuts. Okay, about the discussion, trigeminal artery persistence is a condition that is mostly asymptomatic. However, it is associated with a higher frequency of other cerebrovascular morphological alterations. Therefore, its findings should be a reason for an exhaustive anatomical study. Furthermore, it is important to highlight its relationship with clinical conditions such as ischemic cerebrovascular disease, oculomotor nerve involvement, and as an infrequent and potentially treatable cause of trigeminal neuralgia. In conclusion, a persistent trigeminal artery is a non-frequent anatomical variant that could relate with neurological manifestations and vascular abnormalities. MRI is a tool that could be used as a first step in the approach to neurological symptoms. The finding of a persistent trigeminal artery should lead to a subsequent anatomical study. And the study among cerebral angiography, angiotomography, and angioresonance will lead to diagnosis, anatomical classification, and detection of other cerebral alteration and vascular association. There are my references that I used to make this presentation. Thank you for your attention.
Okay, good morning. My name is Ana Karen Marroquín, and I'm going to present to you a case of a feminine of 42 years old. She began with epigastric and mesogastric pain, accompanied by nausea and vomit, for about 6 days of evolution. She came here to our emergency department, and the first thing that doctors took was a blood test. And hypochromic microcytic anemia was evident. So with these results, the surgery department decided to ask for a contrast-enhanced CT to exclude any acute causes. So here in our radiology department, we took a contrast-enhanced CT. So we have here an actual view in venous space of her contrast tomography that shows an irregular that showed an irregular image. Okay, in mesentery that's going to be shown in a minute, partially defined with soft tissue density that was surrounding mesenteric vessels. This mass it starts to appear here in the mesentery around the aorta, and its size was approximately 14 centimeters in its longitudinal axis, and was suggestive of a sclerosing mesenteritis versus a lymphoma. So a biopsy was recommended. It was performed a few days later, where the result by our pathologic department was an atypical lymphoid hyperplasia that was positive to CD20 and BCL2, and also had some confluent lymphoid follicles. So with this result, we can discuss a little bit about an atypical lymphoid hyperplasia. That it's not only one pathology, but it also includes all of these other diseases. The most common one is the reactive follicular hyperplasia. It's the one I'm gonna focus right now. So this reactive follicular hyperplasia is one of the most common forms of benign lymphoid hyperplasia, and it's also the most common one in children and young adults. It has been described in a variety of anatomical sites, including lung, thyroid, orbit, gastrointestinal tract, pancreas, and skin. The author took it, and his team described a rare case of reactive lymphoid hyperplasia of the liver. These are the images that they share in their article. It was a rare case of a 61-year-old woman who presented abdominal pain. She had history of common variable immunodeficiency, and in here we can see 3 images of contrast enhanced CT, and we can see in segment 6 of the liver, of her liver, a lesion in low attenuation. It's okay here, right here. It has low attenuation relative to the rest of the normal liver. Following the intravenous contrast administration, it was isoattenuating, and in portal venous phase, it showed as a low attenuation lesion. It was resected, all of the segment 6. Using intraoperative ultrasound to localize the lesion, and the final histopathologic result was of a reactive follicular hyperplasia. Another one of our differential diagnoses was lymphoma. It represents approximately 1/4 of all retroperitoneal tumors, and this one is considered the most common retroperitoneal malignancy. They typically begin as a local lymph node enlargement, and then it spreads through lymphatics to adjacent lymph nodes, sometimes creating conglomerate nodal masses that characteristically infiltrate the perinephric spaces of the retroperitoneum. Here, the author shares a case of a 54-year-old man who presented also abdominal pain, as well as our patients. And in his contrast-enhanced CT, we can see an homogeneous, lobulated, and minimally enhancing retroperitoneal mass without necrosis or calcification. We can see also that the major vessels are well encased, giving a positive CT angiogram sign, which is characteristic of lymphoma. Our third differential diagnosis was sclerosing mesenteritis, which in our patient, it was our first option. This one is an idiopathic inflammatory and fibrotic disorder affecting mesentery. It has an unknown etiology and typically causes an acute mesenteritis, which can be cause of abdominal pain. There are 2 types of sclerosing mesenteritis. We can have an acute presentation or a chronic one. In the acute presentation, in our imaging studies, we can see an increase of the attenuation of the mesentery with fat stranding and induration. It also known as misty mesentery, with a thin pseudocapsule, which is usually less than 3 millimeters, and a cluster of mildly enlarged mesenteric nodes. While the chronic one, it can be seen as a discrete fibrotic soft tissue mass with a spastic reaction and an encasement of mesenteric vessels. The treatment for this pathology, it has been immunosuppressive therapy, which usually has a good result, a positive result. And the author shared these two images. The first one is an axial contrast enhanced CT in a patient with pain and fever. And in our image, it showed an infiltration of the jejunal mesentery demarcated by a thin pseudocapsule. It also had multiple prominent mesenteric nodes that were present with a fat halo around them. This is an example of a typical acute sclerosing mesentery. And the second image on the right, it shows an actual contrast CT in an elderly woman with chronic pain and diarrhea. It showed soft tissue mass at the base of the small bowel mesentery, which was encasing and narrowing the mesenteric vessels. And this was found after performing a biopsy to be a chronic sclerosing mesentery. And for my case, well, this is all. This was the bibliography I used.
Okay, good morning. My name is Mario Nunez. I'm a second year resident of the radiology department of the hospital of Jose Eleuterio Gonzalez. Okay, so we're starting with the case presentation. This is a 42-year-old male with no relevant personal pathologic issues. He had 5 months of cough. He referred weight loss since March 2021, but in May 4, he started with cognition impairment, aphasia, and fever. And at our institution, he was diagnosed with HIV. So imaging studies were requested for his neurological impairment. So now we're seeing a CT scan of the head, and there we can see some okay. Right here we can see 2 extra intra-axial lesions right in the left frontal lobe with some vasogenic edema. It has, well, a large amount of it, but we can see here some hypotensities also in relation with edema here in the right frontal lobe, and also here in both of the internal capsules, and another one right here in the occipital right lobe. Here in the coronal view, we can see also the same lesions right here, and also these lesions are causing the parenchyma brain compression, and also a subpulsing hernia right here. The largest lesion that we can see here, its measurements are like 32 by 24 by 20 millimeters, the longest one. And with all these findings, we suggested a infectious disease. And after a week of the CT scan, MRI was requested. But also we have to say that this patient had seizures episode before this MRI. So in the MRI, we have T2 weighted images. Here, we can see the same lesions that are rounded, and also the pathogenic edema around of it that are better seen here in the flare technique, with a sign called target sign that are well circumscribed borders or well circumscribed ring here. And in the flare, we can see better the other lesions that has also edema here in the right frontal lobe, in the both internal capsules right here. And now we can see better there are more lesions that weren't apparent in the CT scan. Also here in the occipital right lobe. Okay. In the diffusion technique, we can see that the lesions right here, they have some a partial restriction in the diffusion technique. And with the apparent diffusion coefficient map, or ADC, we can see that this is a truly restriction and not a T2 chain effect. Okay. Now we have the C1 weighted images. Here we can see the lesions that were in the left frontal lobe. They are isentense relative to the gray substance right here. And in the C1 contrast enhancement with gadolinium, we can see these lesions has a prominent rim enhancement. It is also nodular enhancement, and this is called a target sign. Here is another one. And you can see also the other lesions that have only edema. You can see also the target sign, demonstrating more lesions. Okay. So the patient was suspected with encephalitis infectious. So a serology was performed based on immunoglobulin G in the ELISA technique, and the conclusion was that it has toxoplasmosis positive. The patient had a treatment with pyrimethamine with 50 milligrams per day for 3 weeks, and the patient had a fully recovering of his symptoms, and he was discharged after 3 weeks of the treatment. So I'm going to make a review of the toxoplasmosis encephalitis. First of all, we can see that the pathology of the Toxoplasma agent, we have that it is from the cat. We can see that is the principal host, and he with his feces he makes a fecal oocyst that, if they are in the soil or the water, the animals that can consume them, they are the rodents like mice or birds. So the oocytes transform into tachyzoids in the neural and muscle tissue, and therefore it develops like bradyzoids in the tissue that other cats can consume it and get infectious also. So in the human, we can have several forms of transmission. One of them is that animals that we can eat them, like the pork or the beef, they consume some soil or food contaminated with cat feces, and then we can consume those animals, and we can get the infectious disease, or directly from the food or water contaminated, or also if we have pets, we can get it from the soil. And also, our transmission ways is the transfusion or from organ transplantation, and also from mother to fetus via transplacentally. There are other forms. In the US population, we have 20 to 70% of seropositive for Toxoplasma gondii. Usually they have a latent infection. The definitive host is a cat. Okay. In the clinical issues, we have a presentation most common with fever, malaise, a headache, but later it can be like personality change or seizure like our patients. In the epidemiology, we have the central nervous system Toxoplasma encephalitis. It occurs in 3 to 10% of AIDS patients there in USA reported, and it's more common when the patient with HIV had a cell count of CD4 less than 200 cells per microliter. The treatment is based with antibiotics like pyrimethamine plus sulfidazine, but also trimethoprim with sulfamethoxazole is an alternative. The Toxoplasma encephalitis lesions they usually resolve in 2 to 4 weeks after the treatment. But if it has a lack of resolution, it suggests another etiology. And in the imaging, we have the most common location there in the basal ganglia, in the corticomedullary junction, in the thalamus, cerebellum, or like our patient had. And the size are medium, like 2 to 3 centimeters in diameter. And the morphology, they're round or oval, like here in the CT with a contrast enhancement. We can see here like a round lesions, and over here, and also here. In a non-enhancement contrast CT, we can see that there are ill-defined hypodense lesions with edema, and the edema is also more prominent than the lesions are. Here we can see them. This is a contrast enhancement, and with the contrast enhancement, we can see the multiple rim nodular enhancement masses. In the T2 weighted images, we can see they're hypointense, or also they're hyperintense with peripheral edema. This is the images of our case. Here we can see like these ones. It has a lot of edema relative to the small lesion, and they are disproportionately larger than the relative of the lesion size. In the flare, we can see the target sign, and this is very useful for making the diagnosis. Even not with the contrast enhancement. In the diffusion technique, we can see the restrictive area in the necrotic centers, like we had in here in the lesions. And with the contrast enhancement T1 weighted images, we can see the target sign with a ring nodular punctate enhancement. If we had a perfusion weighted imaging, PWI, we can see that the lesions had a hypovascular or extremely hypovascular view, and it's like a differential diagnosis for tumors or masses. Okay, so the differential imaging diagnosis is when you have a HIV patient with a central nervous system with mass effect, you have to think about toxoplasmosis, but also you have to rule out primary central nervous system lymphoma. With the primary central nervous system lymphoma, I'm going to present this case of the 45-year-old male with subacute history of weakness and altered sensorium. We have only an image of a T2 weighted MRI and a contrast enhancement MRI. Where the T2 image you can see there is a mass demonstrating homogeneous and hyperintense mass. In the contrast enhancement, you can see that there is no the ring or target sign. You can see only patchy enhancement post-gadolinium administration. And in the diffusion images, you can see a prominent restriction area that with the ADC map, you can see that it's a truly restriction area. And this makes you think about lymphoma against toxoplasmosis. Okay, so that's all my case. Thank you very much.
Good morning. My name is Miguel Ángel García Rosales. I'm second year resident of the radiology department, and I want to show you the sequence of events that we have to make the diagnosis of these patients. Okay. It all started when I received a call from the attending doctor, and he asked me if I could evaluate a chest X-ray of a patient who had just arrived at the hospital emergency department and find out if the X-ray showed data suggestive of COVID-19 and take the necessary measures for his care. So here we have the X-ray in posterior anterior position, in which we can observe a normal disposition of the soft tissues without identifying areas of increased density, without fracture or presence of lytic or plastic lesions in the bone structures, as well as abnormal cardiomediastin silhouette without displacement of the trachea. But at the level of the lung fields, we can observe several nodular opacities of bilateral diffuse distribution in the lung parenchyma. These findings are not characteristic of COVID-19, in which we can observe the chest X-ray normal or a patchy peripheral subpleural predominant hazy opacities with or without consolidation. So about the clinical history, this was a case of a 16-year-old male patient with no relevant history for his current condition, which was characterized by diffuse abdominal pain accompanied by unintended weight loss attributed to the same abdominal pain of approximately 1 month of evolution, which was exacerbated and added nausea and vomiting. So here we have the laboratory studies. We can observe elevated white blood cells, neutrophils elevate, and also the uric acid, total bilirubin, direct bilirubin, indirect bilirubin, the triglycerides, and this is the more important results the alkaline phosphatase, and the LDH that was incredibly high. In the okay, then the treatment doctor took this abdominal X-ray, the first in supine position and the second in standing position, in which we can observe increased opacity of the abdominal soft tissues without being able to adequately distinguish the hepatic, splenic, or renal silhouette, which condition displacement of the intestinal loops and which could correspond to hepatomegaly. So the bone structures are normal. So they decide to take a CT, and this was the CT. Here we have a axial venous enchasement CT, in which we can observe in the pulmonary fields and airway multiple round lesions with well-defined edges, with soft tissue density, some with necrotic center, the diffuse distribution in both lung fields, and this suggests that it could be metastatic disease. The largest was here. Here. Okay, we also can see multiple lymph nodes with necrotic center in para-aortic, peritracheal, and superior paratracheal, subcarinal, and bilateral iliac and inferior paratracheal lymph nodes. Here. Here. Also here. Okay. In the evaluation of the abdominal structures, we can see that the liver is increased in his size, consistent with the hepatomegaly, and at the expense of multiple hypodense ovoid lesions with defined borders with peripheric enchasement to the administration of contrast medium. And this also suggests metastatic lesions. Also, we can see a little bit of free fluid here. Oh, bueno. And also here in the pelvic region, but also here in the testicles, we see this in the left testicle, this contrast enchasement here, and we suggest to the treatment doctors to make a testicle sonography, and this was the images. We can see 4 ultrasound images in grayscale, which identifies the right testicle with normal size, and size, echogenicity without evidence of focal or diffuse lesions, and color Doppler evaluation with adequate intratesticular flow. Also, the epididymis was normal. Okay. Here we have the left testicle, in which we can observe this lesion that was epicoic with invasion of the tunica albuginea and the distortion of the normal morphology of the tests. We also see that this lesion has flow with the Doppler, with color Doppler exploration and with spectral evaluation. So with the related team, they decide to, with these Imagen findings, to do a orchiectomy, and this was the piece. And they sent the piece to the pathology department, and it was reported malignant non-seminematosus germinal tumor with 90% of embryonal carcinoma and 10% of endodermal cynosis. Okay. And now I'm going to talk about a little bit of germ cells tumor that are rare tumors in the general population, but are the most commonly occurring malignancy among the males between ages of 15 and 40 to 40 years. The germ cell tumors are classified as either non-seminematosus, and which account for approximately 60% of the tumors, or seminomas, which account of approximately 40% of the tumors. Accurate classification is important because it determines the type of the treatment. Non-seminomas are clinically more aggressive and often include multiple cell types such as embryonal cells carcinoma, choriocarcinoma, Joel sac tumor, and teratoma. The incidence of testicular cancer has been rising and has almost doubled in the past 4 years. Men who are Caucasian have an undescent testicle, are normally the development of testicles, or a family history of the testicular cancer, have a greater risk of developing testicular cancer. The classic presentation of the testicle germ cells tumors is hard swelling with the testis. For most people, this is painless, but about 10 to 20% have some pain. Delay in the diagnosis can occur both from the patient's embracement and from a delayed investigation of this. Testicular tumors are usually diagnosed clinical and pathological at surgery. Imaging of the testis with sonography can help to confirm the presence of intratesticular mass, or if there is uncertainty about the clinical features. Testicular sonography is also helpful in assessing patients who present with metastatic disease in whom an occult primary tumor of the testis is suspected, or examine the contralateral testis to identify the small number of patients with bilateral synchronous tumors. Serum tumor markers as alpha-fetoprotein, HCG, and lactate dehydrogenase are critical in diagnosis of these tumors, and also are important to determine prognosis and assessment of the treatment response. Okay. Testicular tumor is spread by the lymphatic route through channels that accompany testicular vessels to the retroperitoneal lymph nodes. Right side tumors spreads to the aortocaval nodes, precaval nodes, and right paracaval and retrocaval nodes. Left side tumor spreads to the left paraortic nodes and preaortic nodes. Also, the testicular tumors have a hematogenous spread which is predominantly to the lungs. Other sites of metastasis in patients with advanced aggressive tumors include brain, bone, and liver. CT remains the imaging technique of choice in staging the testicular germ tumors, and the standard treatment for this tumor is radical orchiectomy and or combination with chemotherapy or radiotherapy or retroperitoneal lymph nodes node desiccation. Furthermore, small is the interfering RNA therapy, microRNA therapy, and immunotherapy are suggested to be potential therapeutic strategies. Okay, this was my reference. That's all. Thank you. And for the junk mail, remember to explore the testicles. Thank you.